All right, I think I will start with the abnormal section now. This is thanks to the resources of Ashley Lau, Myth Gravity, and Mythic FCI. All of the resources are on the site, Google site website. It should all be on there. This is just a very, you know, uh, it's comprehensive. It's detailed, but it's a lot of their resources are very specific, are very good, and it saved my life during my mocks exams and everything too. So this is just a compilation of everything. Of course, only Ashley only did it was no treatment of sorry no the first part of abnormal psych. Mid gravity did etiologies, and then Mythic did treatments uh, of mental illnesses. So this is just a compilation of all their work put into one. So what will we focus on again? Like as I have said, um, topics in abnormal or clinical psychology, as I'd like to call it in uni, factors in diagnosing, factors influencing diagnosis, etiologies, and treatments of disorders. And again, you have a list of potential mental illnesses or conditions that your teacher might have taught you, but for the sake of this, for the sake of actually, depression is actually one of the easiest, um, I guess, quote unquote, behaviors or mental illnesses that we can talk about. It's the one that's been researched a lot, in my opinion, I think. But let's get straight into it. We have factors influencing diagnosis here as part of our first part. So let's show some of the possible ERQs that this part might have. So the role of sociocultural factors in diagnosis and the concept of normality and abnormality. So first, let's define abnormality as a deviation from social norms. So any behavior that is not socially acceptable in society is considered abnormal. And of course, um, this depends on this society that you live in also. So in I think the Maui, the New Zealand, nice, the New Zealand, in New Zealand, the Maui people, I think that's what they call it. They actually, they actually they use tattoos for warriors. I think even females get tattoos. That's why I believe. So it's very considered. It's normal. It's considered very normal to them, but it may be considered abnormal to other cultures. And again, it's the oldest definition of abnormality there is, and it's used mostly to diagnose behaviors that are abnormal. So pros suggest a simple and intuitively appealing definition of abnormality based on common sense. But cons, the lack of cross-cultural and temporal validity and considerations. What you consider to be normal in one culture might not be considered abnormal in another. And again, it's very ethically dangerous. A lot of ethical considerations goes into diagnosing um, abnormal behavior because, as I said before, an abnormal behavior in a behavior that's seen as abnormal in one culture may actually be seen as very normal in another culture. Does not account for behaviors that are socially acceptable but harmful to the individual. I guess I can't think of one from the top of my head right now. But it also does not take into account of differences in social norms, again, and context. Again, like falling asleep in the cinema versus falling asleep in a meeting, you know. So it also doesn't take into account of the context that this abnormal behavior goes into. And yeah, China uses the. I have it somewhere in here in the slides, but China uses a different diagnostic manual. So let's look at abnormality as inadequate functioning. So Rosenhan and Seligman, very popular, proposed these 7 criteria of abnormality and suggested the degrees of abnormality that can be established based on combinations of these criteria. You can go take a look at them. Go take a look at them later. It's a bit long, but it should be in the textbook somewhere. Oops. Um, so again, pros, it includes more definitions of abnormality, socially acceptable behavior that causes individual suffering, and it operationalizes abnormal behavior in a way that can be established by observation. And of course, the cons here, definitions are over-inclusive. So public displays of affection maybe cause observer discomfort in some cultures, but is it enough for it to be classified as abnormal behavior? And then there are some exceptions and contradictions. There's personal distress, there's maladaptiveness, unpredictability, and unconventionality. And then you have down here, I can't move my mouse to it because the thingy will overlay it. It's very subjective. So the fulfillment of criteria may be judged differently from person to person. And again, very few behaviors might meet all three criteria. Yeah. And let's look at abnormality as a deviation from ideal mental health. So Jahoda suggested that defining ideal mental health helps us recognize mental disorders. And she proposed 6 characteristics of ideal mental health, which is the efficient whatever, you can read it yourself. I'm not going to read it out loud. Fuck that shit. So we have pros here, which is, it's very humanistic. It's a very humanistic approach to diagnosing, which focuses on health rather than disorders, provides a balanced description of what it means to be healthy. So instead of focusing on what is unhealthy, focus on what is healthy, and then focus on how to change those unhealthy habits or disorders into healthy ones. And then we have the cons here, which is low scores in criteria can be due to factors other than abnormalities. So you have socioeconomic factors such as poverty, and some characteristics are difficult to measure. It's subjective. It's also ethnocentric. That's a very good vocab there to use in your ERQs and SEQs. It lacks cross-cultural validity, and it does not take into account extent and duration of symptoms, and temporal validity here, because this model has been older than 60 plus years. And then let's look at abnormality as a statistical infrequency. So we assume there's an assumption that there is such a thing as average or frequently occurring behavior. So these behavior that the behaviors that occur infrequently is considered to be abnormal and attributed to mental health. So let's look at the pros of this. It's quantifiable and objective. So traits and behaviors are compared to those of a large representative population. So emotion and culture are not involved. But the cons here is that it's difficult to measure and quantify some behaviors. And these behaviors might, differ from person to person. And it does not consider behavior in context. And it lacks, again, temporal validity. And because, again, you have to understand that cultures are dynamics, and the people living in those cultures and everything, statistical norms are changeable. They're dynamic. And of course, we have increased prevalence of overt homosexuality and increase in average IQ as an example. Lack of temporal validity there. You should know that actually homosexuality was classified as a mental disorder in the DSM-1, 2, and 3, I think. And again, a con here is that it's statistically infrequent. The behaviors that are statistically infrequent are not always undesirable, such as unusual high IQ, like the really smart guy. I can't think of his name right now, I'm brain dead. Einstein, there you go. I'm not totally brain dead. And then we have the medical model of abnormality, which assumes that abnormal behavior has a set of symptoms and has a set of causes behind those symptoms. So this is called etiologies. symptoms may be observed, causes may be inferred, and treatment should target those inferred causes. So the pros are avoids the need for general definition of abnormal behavior and instead focuses on defining individual mental disorders by their symptoms and bring them together in a classification system. It's also very objective. It defines mental disorders by their by the observable symptoms. It makes diagnoses independent of the clinician's beliefs regarding what causes the disorder. And again, very testifiable, can be tested and refined against empirical observations using the DSM and whatnot. And we have cons, which one of them is that many symptoms of mental disorders are not as easily observed as symptoms of physical disease. And actually, let me actually find, this is my uni work here. Trying to find a document that actually shows diagnoses of anxiety, depression, and all those mental disorders that shares a lot of similar traits or similar behaviors. Let me just take a moment here. Yeah, maybe this is it. So we have let's see if I can find it. By the way, basically, weakness to that is that, oh, did not mean to share. I'm scuffed. Basically, the con of that means that some of these symptoms may fall under various mental disorders. And it's hard to correctly diagnose what mental disorder this is. And again, lacks explicitness. A symptom may be as I said there, maybe an indicator of multiple disorders. Actually, the term for that is called burden of many diseases, I think. That's what it's called. And then another con here is problem of threshold. If some symptoms are present but others are not, do we still diagnose a disorder? Let's look at another possible ERQ question. Contrast two classification systems of abnormal psychology that you guys have talked about in chat, as I can read here. So the Western culture, of course, uses the DSM, which is published by the APA, and of course has its sets of pros and cons. It's widely used in the US, Canada, Australia, and Hong Kong. Remember here that even though Hong Kong it's in Asia, it's been colonized, so it may bring a very different culture, and even Singapore too, I believe. But yes, so its pros is that the number of revisions that it has have incorporated feedback from professionals, from psychologists around the world. The DSM introduces the axes and saw a shift from establishing causes of disorders based on the clinician's interpretation of the client's behavior to describing a set of observable symptoms and trying to create classifications, categories that would not overlap. So this theoretically made it easier for professionals coming from variety different backgrounds to arrive at the same diagnoses. Again, cons here following the shift, number of diagnoses has increased from 128 in version 1 to 541 different mental disorders in version 5. It's a lot. So basically, we're all diagnosed with mental disorders. So the question here is, are they all valid diagnoses? Such as caffeine withdrawal, central sleep apnea. Are these mental or physical? And are they best addressed by a classification system pertaining to mental disorders? Again, it lacks cultural consideration, so ethnocentric, and despite specificity, criteria can be interpreted subjectively. And we go to the Chinese classification of mental disorders diagnostic manual, the CCMD, which lack of lack of the cross-cultural validity from the DSM has led to the creation of diagnostic manuals from other countries that's more country-specific, like the CCMD, which actually focuses on more somatic, emphasizes somatic and behavioral symptoms over affective symptoms in diagnosing patients. So a patient who might be depressed in the Western culture might show, change in eating patterns, maybe less responsive, etc. But what the Chinese have found is that it can actually be somatic. So your stomach might be hurting, or your head might hurt. So that's the difference between the classification system. Of course, the con here is that it contains diagnosis for things Western society would disagree are mental disorders. And the CSP has been criticized for being complicit in government oppression and political dissidence. So let's look at other ERQ questions. Discuss the role of cognitive factors in diagnosis and discuss the role of clinical biases in diagnosis. So we have the Sigrel bias here, which a clinician, which is a clinician variable. When a person comes to a clinic and seeks for assistance, we automatically assume that there is a problem, and we have to diagnose that issue before it's no longer disorder. So Rose and Han here, a very famous study, and we have actually Confederates who faked suffering hallucinations, and they went into mental hospitals, and some of them were actually trapped there for a few months before they're given freedom to, they're given, they're declared as the issue as solved, basically. So a pro here has high ecological validity. It's done naturally and demonstrated the invalidity of diagnosis, basically. That the Sigrel bias might play a role, but really it lacks temporal validity. I think I should have put the cons there. Since the study, the DSM has undergone many changes. So diagnosis then and now would be different. Of course, we have cultural bias, where diagnosis based on different cultures may be different, obviously. So the pros here is that questionnaire used was relevant to the participants, as based on both mood and cognitive items common in Western diagnostic tools, as well as somatic symptoms commonly observed in Singaporean psychiatrists. The cons here is that the methodology is a bit faulty. It may lead to underestimation of differences. In post-ethic approach, it's retrospective self-reporting, so we might have demand characteristics here, and reliability is a big question here. Malaysia is a relatively modern and westernized society, so effects of globalization, acculturation, and such may account for the relatively small difference in data. And then we have a few more cons here, which you can read by yourself. And then we go to the validity of diagnosis. So again, like the study that I just said, Rose and Han with the Confederates, the actors going to mental hospitals and faking their symptoms. And some of them were actually stuck inside the mental hospital for a few months. So it really demonstrated it really questioned the validity of diagnosis there. Of course, cons, researcher bias, generalizability, temporal validity, because the DSM has been through many versions, and ethical considerations also. No consent was given by hospital staff. And participants used deception to gain admission into hospital, and Rosenhan did not debrief hospitals of his findings. So that's this is a good study if the ERQ asks you to evaluate or discuss the ethical considerations. Library pack here, yeah, same thing we talked about earlier. Cultural bias here. Read it for yourself. And then we have discussed the reliability of diagnosis. We have Lipton and Simon, which this is an important aspect of diagnosis because you want to be accurate in diagnosing. So what they did here, you can read for themselves. The pros is that the test-retest method is realistic, and the cons is that it's in a naturalistic setting. So we might find confounding variables, and again, temporal validity. The study done using DSM-5, DSM-3, but the current edition is DSM-5. So a lot of these studies lack temporal validity, and these are the critical thinking points that you might have within your ERQs. And then we have Lobestale, Stat-Ale, I'm not going to try to pronounce that, fuck that shit. So the procedure here, they set up clinical interviews, and the findings is that 85% of reliability of diagnosis for personality disorders, and 70% reliability of diagnosing depression. So pros, higher rates of reliability than in older studies. This is done in 2011 using DSM-3, suggests that improvements in diagnostic guides increases reliability of diagnosis. Oh, oops. And the cons is that it's a single-blind procedure. It's artificial, so therefore lacks ecological validity, and it's not directly comparable with Lipton and Simon, because many more disorders introduced into the following revisions of the DSM. Axes were introduced in the DSM-3. So that's all for part A of abnormal psych. We now move on to etiologies, which Mid-Gravity here has done for 2019, I believe. Oh, I didn't mean to share. Present. So again, focusing on major depressive disorder, also shortened as MDD or depression. It's diagnosed as an individual experiences 2 weeks of either a depressed mood or a loss of interest and pleasure. In addition, the diagnosis requires the presence of at least 4 additional symptoms, such as insomnia, appetite disturbances, loss of energy, feelings of worthlessness, thoughts of suicide, or diminished ability to concentrate. And we follow this kind of figure here, the model, ABC's model. So we have the affective symptoms, feelings of guilt and sadness, lack of enjoyment or pleasure, behavioral symptoms, passivity, lack of initiative, cognitive symptoms, frequently negative thoughts, low self-esteem, yada yada. And then we have somatic symptoms as well, loss of energy, insomnia, or diminished libido, you're not horny enough. Don't laugh at me. All right, so let's go into the etiologies of depression. Let's go in with the biological first. So as studied in the core section, there are a lot of studies. Okay, I should mention that the abnormal psych is the weirdest section, weirdest option for psych, because really you're taking everything you've learned in the core topics and you're trying to put it into application. And that's what you should be writing for your ERQs. It's less about the studies themselves. It's more about how you're using that study to show etiologies or to show application of the of depression. So twin studies, of course, Kendler et al. Adoption studies, I can't remember. Family studies and molecular genetics, molecular here being Caspi, very, very famous. You should use that as one of your study library. Um, so yeah, so this is Kenla, I believe. It doesn't say, but basically, yeah, I think this is Kenla. Either way, if it's not Kenla, go ask your teacher for Kenla. It's a really good study. So twins, yep, MZ twins, monozygotic twins, share 100% of their genotype, whereas dizygotic twins share about 50%. So MZ twins should have similar behavior compared to DZ twins. Adoption studies are useful to study the effect of change in environment on children. So you can compare similarities and differences of adoptive children with their adoptive parents, biological siblings, and other siblings. Family studies based on family data for several generations, and epigenetics, that's CASPI right there, using genetic mapping. And then we have the Falconer model here, used to estimate heritability in twin studies. Phenotype is based on the combination of A, C, and E. Let's let the thingy not cover here. So we have A plus C plus E equals to 1. Closer to 1, the more closer it is, I guess. The male. So yep, Kendall right here, 2006. Don't think it's 2009 cat. Or 2000. I don't fucking know. Just write Kendall et al. In your fucking ERQ. Oh, SAQ. You should all know this study. Go study it. It's very interesting. And it explains it highlights the important role of gene-environment interaction, which is the idea that genes may predispose an individual to depression. But actually here, Silberg found similar results to Kendall as well, and he did a longitudinal study in which he found that girls actually are more vulnerable than boys to stressful life events and have higher likelihood of developing NDD. So this is actually how you should be writing your ERQs. You're not, you might go and say like, oh, he did this and that's his method. But really, you should be including info that's relevant. You don't want to say, he did this, he did that, the method is this, results are yada, yada, yada. You want to say really quickly what he did, what he found, and why it contributes to the issue that you're talking about. And then use other studies as well. Very not in depth. I can't think of the word right now. Like what mid-gravity did right here, just to add on to your point. And then we have CASPI et al. Here, the serotonin hypothesis. You should all know this. I'm not going to go over it. You can go over it yourself. Fuck that shit. Findings, yep, conclusions that people with at least one short allele of the 5-HTTP gene are more likely to experience depression with higher number of stressful life events that they have up to 26 years old. Yep, CASPI provided GXE, but disregarded the RGE, which is the concept of gene-environment correlation that says that relationship between genes and environments is a lot more dynamic and complex, and genetics can influence the environment itself. So we have passive RGE. Parents can pass on onto child A and E, so A and E are not entirely separate. Evocative RGE, a genotype evokes environment response, and then we have active RGE, which is niche picking. Individuals selects the environment to match their A. So going back, A here is the hereditary genes. So, yep, biological explanation of depression. We have the serotonin hypothesis there, as I just mentioned, which said that the imbalance of serotonin is the reason for the onset of depression. We have seen this with CASPI. And this is further researched, which shows drugs like Prozac, which is SSRI restore chemical balance of serotonin. helps alleviate symptoms of depression, shown by Rossi, who did a meta-analysis. Simeone showed through a study with a placebo and Prozac that symptoms were alleviated on 2 out of 3 of uh, hetero, uh, hetero something alleles in both cases, but some always persisted, showing that Prozac and other SSRIs might not be the perfect MDD treatment resolution. Yeah, it's a lot of studies, but the thing here is that you're not you're not really memorizing like every detail of it. You're using the studies to build on the original study that you want to focus on. So think of it as a literature analysis. So you're focusing on this one big study, let's say CASP, and then you're using other studies just to build on to the arguments that you've had. Modern research has also shifted focus to the neurogenesis theories of depression. Theory argues that depression is the result of the cessation of neuron birth in the hippocampus, as well as in other neural networks related to serotonin, dopamine, and norepinephrine. Cortisol appears to be the reason for the lack of neurogenesis as well. Patients with with depression display a symptom called HPA axis hyperactivity that results in the oversecretion of cortisol. This oversecretion of cortisol is reduced to serotonin, leads to reduced serotonin. Actually, avoid saying like leads to, because it's very, I guess, causal. It's a very causal vocabulary. We don't want to say absolute things in psych and sciencey stuff. So may be linked to reduced serotonin and other neurotransmitters in the brain. And this is demonstrated by Videbech and Ravnkild, if I pronounced that correctly. Actually, I think that's pronounced as Videbek, but I just wanted to say the word bitch, because that's who I am. So let's go to the cognitive explanation for depression. So we have Beck's cognitive theory of depression, where a negative change in automatic thoughts can lead to a change in behavior. This is the cognitive triad, basically. A negative view of the self, the world, and the future. So negative of the self, of yourself, might affect the world, and then might affect your future. And then you have the negative self-schemata also, which is individuals start attributing all negative life events as their own fault, even when they can't control such events. And then you have the faulty thinking patterns, which are just biases, irrational thinking, and it's described here on the side here. Personalization, this is my fault, exaggeration, arbitrary inferences, binary thinking, selective abstraction, and overgeneralization. So we have the key study here, Alloy et al., negative cognitive style. Investigate whether negative or positive cognitive styles give rise to depression symptoms. Participants depressed randomly sampled college freshmen. Procedures here, start of a longitudinal quasi-experiment. Participants followed then for 5.5 and assessed in intervals through interviews and self-reported questionnaires. Yes, Alloy, my main man. So results are here. Participants are more likely to develop depression than low risk, whatever the numbers are. I don't understand those. Just write it in your fucking ERQ and they'll understand it. And high risk VE-COG participants are more likely to, so in this condition, participants are more likely to develop suicidal thoughts and behavior than low risk. And really, this is all you have to know about the study or memorize the study to bring into the exam room. You don't need to memorize it so specifically because you have other studies to support this main study as well. And then we have Abramson, which is the hopelessness theory of depression. So basically it's like your hopelessness, like you've lost your sense of hope. Here, failures which underpins the sense of hopelessness, commonly described as depressed patients and associated with suicide. So depressed attributional style attributes failings to factors which are internal, stable, or global, and global. And those with depressive attributional style feel personally responsible when things go badly. So these factors are either external, unstable, or specific. This is in contrast to the non-depressed person who attributes failings to factors. So let's evaluate DAS, which is depressive attributional style. The strength is that Beck reliably attempted to quantify hopelessness in his theory as well. And Seligman developed ASQ, which provides an assessment of each of the three factors. Found that when students who received poor exam results, who received poor exam results and felt depressed, completed the ASQ, and those who showed non-DAS had recovered within 2 days, whilst those with DAS still felt pretty depressed. The weaknesses, of course, hopelessness is an arbitrary concept. Hopelessness may be consequence of depression, not a cause. Nolan Hoey Sema observed no association between DAS and depression in longitudinal study on a few children, but saw the development of DAS after symptoms of depression. Yep, and that term is called bidirectional ambiguity. Yep, very good. So you don't know if one factor affects the other or if it's that factor affecting the other factor. And let's move on to the social cultural explanation. We have Brown and Harris, very good study to keep in your pocket also. You can read that yourself on the slides, it's very short. And so we have these vulnerability model of depression, and these factors influence the onset of depression at a social cultural level. So we have protective factors, and these factors decrease the risk of depression in combination with particularly stressful life events. For example, a strong sense of community or a close bond with a family member. And then we have vulnerability factors, and these factors increase the risk of depression in combination with particularly stressful life events. The most significant vulnerability factors were 1, loss of one's mother before the age of 11, 2, lack of confiding relationships, and 3, more than 3 children under the age of 14 at home, and 4, unemployment. And then you have 3 provoking agents, acute and ongoing stress. And so we have Kivela here to investigate the social factors that might predict onset of depression. Results are that 8% of men and 9% of women were diagnosed with depression. And comparison of depressed versus non-depressed men showed most common predictors for depression are poor spouse relation, negative behavior relationships, loss of mother when under 20 years of age, grandchild's divorce, loss of mother when under 20 years of, moving to institutional care, and alcoholic problems. Actually, you will find that in my uni class also, women are diagnosed with higher levels of depression just because of other factors such as, more expectations are placed onto them and such. Hello? Oh, and that's it. That's it with the etiologies for depression. And then we move on to a very short, actually only 3 slides, treatment of disorders. So we have the biological and psychological treatments here. So the 2 main approaches are that biological with biological, we have chemical drug therapy focusing on changing biological aspects, influencing depression. And with psychological, we have CBT, so cognitive behavioral therapy, um, focusing on changing cognitive aspects, influencing depression. So using models like the serotonin hypothesis, we use drugs to manipulate the effects of neurotransmitters, inhibiting VE response, negative VE response, and increasing positive VE ones. And with the CBT, we use, this is based on the cognitive theory of depression, the etiology, that patients work with therapists, perform activities such as Socratic questioning, keeping records of one's thoughts to correct negative VE cognition. And the three main components are that behavioral activation, modifying automatic thoughts, and modification of core schemas. Remember that from our core topic, schemas are really, really hard to change. And we have to try to modify these core schemas to change our automatic thoughts and activate specific behaviors that are positive. And with drug therapy and CBT, it can be combined. It's known as combined therapy. However, this requires more effort on part of the patient and therapist, psychiatrist. So how do we judge the effectiveness of treatment? Well, we can look at the response rate, which is the percentage of participants who, after treatment, shows reduction in symptoms, or the remission rate, percentage of population who, after treatment, show near elimination of symptoms, or we have the relapse rate, which is percentage of population whose past condition reoccurs. So we have a few studies here. Kirsch found, considering published and unpublished studies, and found that 80% of effects of SSRIs could be attributed to placebo, which casts doubt upon drug therapy. TAD's study found that combining therapy had highest short and long-term remission rates, that effectiveness of all treatments increases over time, and that drug therapy alone had higher short-term but not long-term remission rates than CBT alone. And then you have Holland as well. Read that yourself. And we have, again, cultural specific treatments. This, I'd like to really reiterate and emphasize on the fact that you have to have cultural aspects in your ERQ, because it plays such a huge role in all psychological, in all areas of psychology. So of course, psychological factors may influence, cultural factors may influence the effectiveness and appropriateness of treatment. Adapting existing treatments to certain cultures may not always be the best course of action. So Hodges and Owe here showed that in China, arguments formed in relation with Hofstede's cultural dimensions, high long-term orientation of Chinese culture allows for greater acceptance of CBT activities. And with higher power distance of Chinese cultures means authority, the instructions will be followed because doctors are highly respected. And then you have patients here who might be hiding their own feelings or beliefs, pretends as if treatment is working, possibly to avoid embarrassment or shame. So that's a criticism right there. Kinsey also found that Southeast Asian patients undergoing drug therapy not to take medicine, but to comply with treatment increased after discussion. So possible support of this tendency. And then you have, sometimes it may be more effective to adapt the treatment to the culture rather than to just force a type of culture into a type of treatment into a culture. So Nyam and Grinner and Smith both did that very well. Recommended studies. And that is it for the slideshows. And I actually have a few here actually. Let's look at the uni work that I have and see if it's any relevant at all to you. Let's see. Yes, diatheses for depression. So very much like what I said there. The diatheses stress model. So stress plays a really huge role in depression also. If you would like to learn more about this in uni, most mental disorders involve the combined action of personality vulnerability, which is called diathesis, and environmental stress. So this creates a diathesis stress perspective. That no disorder is without diathesis, no expression of diathesis without stress. Both diathesis and stress vary by degrees, and that levels of stress required to trigger disorder depends on degree of diathesis. So this can actually be seen in CASPI as well. Level of risk, so the threshold for a disorder here is, if you have higher level of risk, you are more likely to experience extreme stress. And if you have lower levels of risk here, you will probably experience milder levels of stress. Yeah, so right here. And specific diathesis for depression here is that the susceptibility to interpersonal stressors, define yourself through relationships and maintaining those, and your sensitivity to relationships. And then you also have autonomy, which is personal achievements, the susceptibility to achievement stressors. You may have lost a high job role, and that might be a high stressor. Or you can be very self-critical. So after rejection, you might doubt yourself and roast yourself, like, why am I not good enough? Or you have a pessimistic attributional style. So internal, stable, global. Yeah, so these are the things that they teach you in IB, very much similar to what you would learn in uni. And yeah, that is basically what I have for abnormal psych. My throat is dying talking 2 hours back to back. But I hope that you guys understand. If you have any questions, or the studies actually, these are all on the revision site. The resources here from Ashley Lau, Mid-Gravity, and Mythic FCI. And if you have any questions, feel free to message me or ask right now, and I'd be happy to answer them to you. And for the human relationships one, if you need the studies related to a topic, feel free to text me and I can send you a file of it or a summary of it that will help you. Yes, and I hope you guys enjoyed. It's a lot of text. It's a lot of, I think I went through it pretty fast. But again, like I said, if you have queries, questions, I'm free this week. I don't have uni this week. I'm on my week break. I'm more than happy to just answer DMs and everything. And that just closes the session right here. Hope you guys enjoyed, and I'll see you guys later. Wanna tell us, but keep looking for one.